Welcome to this last video of this Mastering Endodontic Diagnosis course on YouTube, which is also available on Udemy. So check out this entire playlist or the course, but right now let's jump in periapical diagnosis. Just like we discussed different type of pulpal diagnosis, there are different types of periapical diagnosis. There would be a normal periapical diagnosis, asymptomatic periapical periodontitis, which is SAA for abbreviation, asymptomatic periapical periodontitis, which is AAP. SAP and AAP. So these are the two conditions when there is only periodontitis, like pedial widening can be seen. You might find some hazy lamina dura. It's periodontitis, you only see inflammation, pedial widening, hazy lamina dura, and all those things. If it is painful, it's symptomatic. If it is not painful, it is asymptomatic. Next is acute apical abscess. This is like the biggest emergency in dentistry ever. It can lead to cellulitis and so many serious health conditions that can actually put the patient into risk of passing out or dying. And this is the biggest dental emergency that you can think of, one of the biggest dental emergencies. This is when the patient is in extreme pain, a big swelling, and you need emergency treatment for that, which is incision and drainage. You need that abscess, give a path for that abscess to come out as soon as possible. Then chronic apical abscess, which is a common one, that I have a pimple on this tooth, I have a pimple on this tooth, and I have a pimple on this side here, on just under the lingual side here. These are all the reasons when the patient did not go to the dentist when he had the pain for the first time, or did not go to the dentist when there was some kind of flare-up, and now the tooth is dead and the abscess has made a path through the bone and it has come out, and now it has an outlet. So every time there is abscess, it's just draining out in the oral cavity from the buccal vestibule or from the lingual side. So that's the chronic apical abscess. It is not painful, it is not extremely discomforting, but it is something that you need a treatment for as soon as possible. After that comes condensing osteitis. It is just a response to the pulpal inflammation where you see radio opacity. So only condition throughout the endodontic diagnosis where you see an opacity. There are actually two conditions. One is condensing osteitis, when you see some kind of radio opacity, and second is calcification of pulp or pulp stones, where you see some kind of radio opacities in the pulp chamber. Everything else is going to be a radiolucency. So only two radio opacities are going to be condensing osteitis and pulp stones. And there would be a periapical diagnosis for non-endodontic origin. We can go way deeper into the endoperio lesions, but we do not need to, and it's out of the scope of this course when we are just talking about endodontic diagnosis. So these are all the periapical diagnosis that we will learn in the next slide, and we'll do the same thing. We create the entire table. On the left would be normal, symptomatic apical periodontitis, asymptomatic apical periodontitis, acute apical periodontitis, acute apical abscess, chronic apical abscess, cracked tooth, and condensing osteitis. And on the column heads, I will compare them on a few different things. Some will be the same, some will be different. I will see swelling. Is there any external swelling or any kind of swelling that you can see? Is there going to be cold, heat, or EPT related symptom? So we are just going to keep that as one, which simply means the pulp is vital. There is no other meaning to the cold, heat, and EPT test for the periradicular status except that the pulp is vital or non-vital. Then we will talk about pulp status. Just to summarize that information: pain on chewing using bite stick. So bite stick gives us a very good information when you give the patient the tooth loop and they have to bite on that certain part only. What is the response in each condition? Tenderness to percussion goes in hand with the bite response. Then palpation, mobility, probing, periodontal status on the radiograph, pedial status on the radiograph, and treatment of each of these periradicular conditions. So let's dive right into it. So normal, if the periodontium is normal, periradicular tissues are normal, you are not going to see any swelling. The heat and cold response will be normal or depend on the pulpal status. The pulpal status is independent for a normal periapical diagnosis. Pain on chewing and bite stick, there will be no response because the periodontium is normal. Even if the pulp is inflamed and periodontium is normal, then you will not see any response due to the bite stick chewing or pain on chewing or pain on biting. Same as with tender to percussion, no response. Palpation, no response. Mobility, cannot say. If it is there, then it could be due to the periodontal reasons. Probing, we don't know. PDL on the radiograph should appear normal ideally, and you do not need any treatment. So that's how we will compare all other periapical diagnosis. First one being symptomatic periapical periodontitis. Symptomatic apical periodontitis, if it's a periodontitis, you will not see a swelling. The swelling, the reason for swelling is abscess. If there is no swelling, then there is no abscess. That means it's periodontitis. Periodontitis versus abscess. If swelling, acute apical abscess. No swelling but pus draining out, chronic apical abscess. But no abscess, that means it's periodontitis. Symptomatic apical periodontitis, patient has symptoms, that means patient has pain. So cold, heat and APT may give me a result, may not give me a result depending on the pulpal status. So I'll leave this alone. There's a cross on it. Pulp status, I don't care about it. Whatever it is, my complaint, the patient's complaint is right now that when I'm biting on something, I have pain. So what does that mean? When you give the patient tooth loop, then they are saying that I have severe pain on biting. Sometimes they say I can't even tap my teeth together or close my teeth together because it hurt. Tenderness to percussion, severe pain. They might ask you not to try that tap, tap, tap thing because it hurts. Palpation, you may or may not feel anything. Ideally, you should not feel anything because to palpate, there has to be abscess, there has to be swelling. And if it's swelling, then we are jumping to the abscess diagnosis. If it's periodontitis, then ideally there should be nothing to palpate on. It should be kind of normal. Then mobility, we can't say. There's most likely none because if it's there, it's perio-origin. Probing, again, it should not be much. If it is there, then it could be due to perio or some other conditions. What do you see on a PDL? So now it depends that you may see PDL widening or you may see normal PDL depending on when did the complaint start. So if you give patient a new amalgam restoration, new composite restoration, they go home next day, they are here, my tooth hurts, I can't close or bite on my tooth. Answer is, there are some high points, there is some high occlusion. You just grind it off, reduce the occlusion and boom, everything is good. Patient will be comfortable from next day onwards. This was a classic symptomatic apical periodontitis, where you do not need a root canal treatment. You do not need to do a big treatment, and the radiograph will not show you any radiolucency or any PDL widening because it takes at least 14 days to show, 7 to 14 days to show it on the radiograph. First 3 to 12 days you see hazy lamina dura. You may see that, and after 12 days, like up till 14 days, you can see PDL widening on the radiograph as a classic sign. So once again, it may be there, it may not be there. Maybe this complaint was for a long time and patient was just letting it go, but now it is severe. So you are seeing the patient now, but they had this complaint for like 14 days. So it will show on the radiograph. You may give a root canal treatment depending on the case, or just give the patient some analgesics and reduce the high points and let the patient go home, and they might resolve by itself. So that's all about symptomatic apical periodontitis. Next is asymptomatic apical periodontitis. So the patient does not have a pain, patient does not have a chief complaint of periodontitis, then you will not see swelling there. So there will be no swelling in asymptomatic apical periodontitis. As I said, if you see swelling, that means you're going towards apical abscess or chronic apical abscess. Next is cold or heat test. You will not see much response because of the periradicular condition. EPT may give you positive or negative because if you are reaching to the asymptomatic part, then you might have killed the pulp already. The pulp might have died already. So you may see positive or negative, again, irrelevant for asymptomatic apical periodontitis. The reason why you are talking about this whole thing is because there is a radiographic finding. On the radiograph, you saw PDL widening and you're like, oh, I see PDL widening on this tooth, but the patient is not ready to give you any complaint for that particular tooth. And you are like, why do I see a PDL widening on this tooth while there is no complaint? Answer is, it's asymptomatic. No complaint, asymptomatic apical periodontitis. Pulp status, you will see either necrosis or a previously root canal treated tooth most of the times. It could be vital tooth in some cases, but mostly it's going to be necrosis or a previous root canal treated tooth. Pain on chewing or biting, you might not find a relevant response there. That's why it's asymptomatic. Tenderness, it's not there, so that's why it's asymptomatic. Palpation, mobility, and probing, you might not find anything out of it, but on radiograph you will see a pedial breakdown and some apical radiolucency, which is not abscess, just apical radiolucency. And you would wonder like what to do here, like why is this showing some something on the radiograph which is not being proven by the symptoms of the patient. The answer is it's asymptomatic apical periodontitis, and the treatment could be a re-root canal treatment if you think it's because of that, or it could be just some kind of occlusal adjustment or some kind of analgesics or anti-inflammatory drugs. So many different options are available depending on what the case was. If the root canal is perfect and still you see it, that means there is some external resorption. There are there is so much depth to this whole thing, but how do you find it? Using with a radiograph. Accidentally you took a radiograph and you're like, this tooth definitely has some periodontitis, but the patient does not give you a response. So that's asymptomatic apical periodontitis. Alright, let's talk about the most severe case, which is acute apical abscess. The big emergencies in endodontics, like a patient has a swelled up face or really in pain. The chief complaint that the patient gives is, I feel the tooth is like extrusion. You know what extrusion is like. It feels like out of the line, it coming up, and the patient can just say that, I know if I touch like this, it hurts big times. Because now, earlier they used to close properly, but because of the abscess down there, the tooth is being lifted out of the socket and it has been a little bit up, and of course the abscess hurts down there. So as soon as the patient closes their mouth, they feel extreme pain. I know somebody who came to my clinic with a pen in their mouth and they were like, I'm not taking this pen out because as soon as I take this pen out, my teeth touch each other and I feel extreme pain because of it. He did have some inflammation here, like a big swelling right here, and he did not care about that swelling for a long time. I think for at least 3, 4, 5 days he said it was swelled up, but I knew it was going to be okay. But he was now at a point when if he closed the mouth, it hurt so much. So he was there. We had to do incision and drainage. Long story short, this is the very critical emergency in endodontics. What kind of swellings would you see? Yes, you will see intraoral or extraoral swelling. You might see lymphadenopathy, systemic involvement. So it is a very serious condition. You have to keep it as a top priority or top emergency condition in your clinical situation. With a pain this much, the patient might not give you a correct response. So you would say no response or normal response, or the pulp is most likely dead. But again, we do not generalize that. Sometimes one canal is super necrosed and abscessed while the other canal is vital. So long story short, you have to say that it's normal to no response for cold test, heat test, and EPT may be 80 or it may not be 80. We are not 100% sure. Then what's the pulpal status? The pulpal status is necrosed most of the time, and if it's necrosed, then pain on chewing or with bite stick, there is a severe pain. Do not even ask patient to bite on it. He say, I'm not even touching it because it's gonna hurt me so much. And tender to percussion, do not try the mouth mirror bum on that tooth. It's gonna feel a lot pain to the patient, like the patient is going to go crazy. And even if sometimes if you try the adjacent tooth, it will hurt a lot to the patient. So some patients really jump off of your chair, right? So it could be one of those cases when they are actually that anxious. Palpation, you will actually feel something. You can palpate, you can see a swelling, you can see some kind of swelling in the soft tissue, or you can see the bony expansion due to the abscess which is being formed in there. Mobility, you can see grade 1 to grade 2 mobility because of this condition, and there could be an extrusion, which I just said. Extrusion means the tooth feels like coming out of the socket. You won't see it clinically, but the patient would report it, and that's why they do not close their mouth. Probing, it is not relevant much in this case. On the PDL, you may see normal PDL if it just started last night. You can see PDL widening, you can see hazy laminar dura for between 3 to 12 days, or apical radiolucency if it has been a further longer time. What is the treatment? For most emergency cases, if you see extraoral swelling, incision and drainage is the first treatment. You need to establish drainage. That abscess is flaring up inside. It will penetrate different spaces and may cause more systemic involvement. So you want to make sure that you stop it as soon as possible by incision and drainage, and later do a non-surgical or surgical root canal treatment depending on the rest of the case. Also, people prefer extraction in these kind of cases because that would give the fastest way of the abscess to come out. Some patients, like they give up so much on their tooth that they would just want you to take it out so that they feel relieved from the pain. Next one is going to be the chronic apical abscess. What do you see in chronic apical abscess? Do you see swelling? No, you do not see swelling. You only see a small soft tissue pimple or soft tissue ulcer, from which the pus or abscess is draining out. So you see a draining sinus, a pimple, intraoral or sometimes extraoral. I showed you a picture earlier, and you see that there is some kind of drainage established for that excess pus which was giving the patient problem. Maybe in the previous case when he had or she had acute apical abscess, now it has become a chronic because the pus or abscess has found a way out of the periapical area. EPT will give you no response. Most likely the tooth is dead for good and the pulp is necrosed, either necrosed or there is a previous root canal treatment. There is no pain on the chewing. Patient will not complain pain on chewing because the abscess is not causing the pain anymore. It's not extruding the tooth anymore because the abscess has found a way to get out. So as soon as you press on it, some of the abscess will just ooze out from the buccal vestibule and boom, patient has relief. So patient does not complain of pain, or the tooth does not complain or give symptoms of pain because of biting or percussion. Palpation and mobility are irrelevant in this case here, and PDL, you would see apical radiolucency clearly. Later we will talk about periapical granuloma as well as periapical cyst, but for now, this kind of radiolucency with pimple coming out is always associated with chronic periapical abscess. If there is no soft tissue visible and you see a very big periapical lesion with some cystic, with some cortication around the epithelial cortication around it, that means it could be a cyst. But here it is definitely a chronic apical abscess, which you can clearly see on the radiograph. The treatment is going to be root canal treatment or a repeat root canal treatment. Another thing to bring into this whole category is going to be a cracked tooth. Now, a cracked tooth is when the patient bites on something hard. They had a restoration, like mostly amalgam, and they bite something hard, and the restoration will literally, the amalgam does not break, but it makes the rest of the tooth break, right? So when they bite something really hard, the tooth literally like divides into two parts, and it's a big crack. But then, because of the periodontium and because of everything else, it stays together. So there is a crack. You cannot see it, but it's there. It's so tiny and it's so fine that you cannot see it. But when the patient bites on something, the tooth opens like this. This is the crown of the tooth. And with the crack, this tooth opens like this, opens and closes, opens and closes. So does the patient have any swelling? The answer is no, there is no swelling. Is there any pain to cold, heat or EPT? The answer is yes, because it's not a periapical diagnosis. It is actually still diagnosis of an entire tooth, not pulpal, not periapical. It's like the diagnosis of entire tooth. And yes, there is a pain to cold. Cold test will give the patient pain, or the patient has complaint of cold, but the patient has pain relieved by heat. So earlier we learned that in irreversible symptomatic pulpitis, the patient has pain due to heat but is relieved by cold. In cracked tooth, it's opposite. The patient has pain due to cold, which is relieved by heat. So remember these different things together. And next is on biting. So the patient has pain on biting and pain on releasing. How would you differentiate that is, if you patient with a periapical periodontitis or periapical abscess, you give them something to bite on the tooth loop and they bite on it, they want to just let it go and not do it anymore again. But if you do it to give it to the patient with a cracked tooth, they will bite on it and they'll say, but then they will not let it go, because when they let it go, there is again a pain on the release part. So if they bite on it, they feel pain, and when they release it, they feel pain again, because the blood vessels and the pulpal tissue, they are all expanding and contracting inside the cracked tooth. So That's why you will see pain on biting and pain on releasing. Is it tender to percussion? May or may not be, depending on where you are tapping on the crack. And palpation, mobility, and probing will not show much response radiographically. Absolutely normal. The only way you can find it out is by using transillumination or staining technique, which we discussed in the previous lectures. And on the radiograph, it will be normal. Treatment is going to be a root canal treatment only if the crack is on the coronal part. It did not leak down on the root part. I hope you know difference between a vertical root fracture and a cracked tooth. Cracked tooth is in vital tooth with a restoration. Vertical root fracture is mostly in an endodontically treated tooth. So these are two different things, and we discussed two different things for vertical root fracture, which was a narrow pocket, and you will suddenly see a probe drop at some point. So that is a narrow pocket, which is diagnostic of vertical root fracture. Cracked tooth is something which is on a vital tooth with a heavy restoration, where the tooth just cracked into half. And most of the time, you don't even need to do root canal. You can just crown the tooth, or you can put a band around the tooth and tighten the band like an orthodontic band. And that can also pretty much solve everything. Everything else heals by itself. And I think this is also a very common treatment for cracked tooth. Last is condensing osteitis, which I said is the second only radio-opaque lesion other than the pulp stones. Are you going to see anything with the heat, cold, or EPD? May or may not be, not sure. But what is the pulpal status? It is always a grossly carious tooth, which results in condensing osteitis. So it may or may not involve pulp yet, or it can have a irreversible pulpitis asymptomatic, but there is going to be a grossly carious tooth because condensing osteitis is a response to the carious pulp. Next comes pain on biting, no response, nothing on tenderness, no palpation, no mobility, nothing on the radiograph. On the radiograph is when you actually find the radio opacity around the root apex, and you would be like, why is there opacity around the root apex? And that's condensing osteitis, because the osteitis means it is forming a new bone there. And the treatment for that is actually resolving the pulpal complaint or the chief complaint, and may need endodontic treatment or may not need endodontic treatment. While we are here, we should talk about two important things, which is periapical granuloma and periapical cyst. A granuloma is a granulation tissue in the periapical area. Again, it is after the abscess is so much that it is started to become a granulomatous mass, and granuloma is granulomatous mass. So you will see on the left side I have two pictures of the granuloma, and on the right side I have pictures of the apical cyst. They both will show you big radiolucent lesion with a proper defined margin all around the all around the apex of the root. But what you cannot do is differentiate between a periapical granuloma and periapical cyst radiographically or clinically. You can never say that by looking at the radiograph, I can say that it is periapical cyst or periapical granuloma. You can only do it histologically. Why did I mention that? Because there is a common question in national boards which keep asking you this question, that which of these two can only be differentiated histologically or pathologically, but not clinically or radiographically. And answer to that is periapical granuloma and periapical cyst. For the sake of completion, we discussed so many different kind of pulpal status. Why did we discuss so much? Why can't we just jump on the root canal treatment for every single tooth? There are two reasons. First, many times root canal is not the only answer. It may need other kind of treatment or no treatment, or it may be beyond treatment. So there are different levels of it. So that's why establishing a correct endodontic diagnosis is very, very important. Also, there is a big research which shows that the success rate of root canal treatment is highest when it's a vital pulp. That means in irreversible pulpitis cases. Once you see a necrosed pulp without any periapical lesion, then the success rate is second highest. So 93.1% is for vital pulp, while 92.3% is for a non-vital pulp with no lesion. If there is a periapical lesion, then the success rate drops further to 80s. This is a very big systemic research, and they want you to know this research, and the board exams might want you to know this research, but the answer is pretty simple. If it's a vital tooth and you are doing a root canal treatment, definitely the chances are higher compared to if there is a periapical lesion or a cyst or if there's a periapical abscess or some kind of abscess already occurred down in the periapical area, then definitely root canal treatment outcome would be much lower. So that is all about this entire lecture series on endodontic diagnosis. I hope you enjoyed it. I hope you learned big deal from it, and let me know if you have any questions in the comment sections below. Bye. So this was just another video of the complete endodontic diagnosis series on my YouTube channel. So just go on the playlist section and follow along the entire playlist to master endodontic diagnosis for dentistry exams, which include national boards of USA, Canada, ADC, as well as NEET PG exams. And make sure you post in the comment section below if you have any questions around this topic. Subscribe to my channel, share this video with at least one friend, and I'll see you in the next part of this series.